I want to thank everybody for being here tonight, taking time away from your family. And I want to thank BCH to once again have me give this educational and informative talk. I believe this is fifth or sixth time that I've given this. The videos today are a little bit different. So for those of you who have heard this before, at least there will be some new information. So today we are going to focus on clinical presentations of varicose veins, some of the different types of varicose veins, and what are some of the treatment options that is offered at Boulder Community Hospital. Okay, we're going to start with pictures that show some different forms and sizes and locations of varicose veins. These are, by definition, varicose veins in these pictures. They are externally visible, they are bulging, and they can be anywhere in the lower extremities. I'm sure many of you probably have seen them walking down Pearl Street or Farmers Market, have noticed them on people's extremities, or may even have them yourselves. They can be unsightly, but most importantly, they can also be medically dangerous. And we're going to talk about what are some of the dangers that varicose veins can pose to our health. These are by definition not varicose veins. They are brown patches of serpiginous veins under the skin that are called Telangiectasias. So they are not as bulging as varicose veins, and many times they're not as associated with deep underlying valvular issues as varicose veins are. And we will talk more about that. Here are some more examples of Telangiectasias. And then the mildest form of veins that we would like to not see on our legs are called spider veins. And I'm sure you've all heard about spider veins as well. So basically, spider veins are just smaller versions of the Telangiectasias. They are less clumped, less bulging, less purple and blue in discoloration, and they're more scattered. They can be anywhere from less than 1 millimeter in size to about 1 millimeter in size. And they can be very faint, as well as somewhat prominent, as you can see on these pictures. Wanted to mention at this time that in general, treatment of spider veins are considered cosmetic. So we are not going to be talking about any potential health risks to spider veins because there really aren't any. They are mostly cosmetic. However, spider veins can happen in conjunction with larger vein abnormalities such as the varicose veins. Okay, so we've just now talked about different forms of varicose veins. And I see many patients who come to me who have various symptoms in their legs, but you look at them and they really don't have any of those veins that we just talked about, but they clearly have symptoms. We will talk about what those symptoms are, and I am always amazed when I do an ultrasound on those patients what I find many times underneath. So varicose veins in general affect half of the population of women and about 1/3 of the men. So that's a lot of patients and a lot of the population that have varicose veins. The incidence definitely increased with age and also overall BMI. And that makes sense in that as we get older, our tissues aren't as full of collagen. They're not as elastic. They are more loose. They are more prone to gravity damages. If you add that increased BMI and increased body weight, for example, those COVID pounds, on top of gravity and age, that really significantly increase our chance of developing varicose veins. And again, in this talk, you will understand what exactly is causing those varicose veins. There are lots of patients who have also family history. My mom had varicose veins. My sister has lots of varicose veins. I saw how bad my dad's legs were, and I really don't want to get there. So I'm sure we've all heard about that too. So congenital predisposition definitely also plays a role in how or who and how badly do we develop varicose veins. Again, we've mentioned this before, they are truly not just cosmetic. And I think to this point is why we're finding insurance companies, given the appropriate medical conditions, are actually paying for treatment of varicose veins. Okay, so what are some of the symptoms of varicose veins? Easily to remember is hasty or signs or hasty signs, and that's heaviness, achiness. I have really achy legs. My legs feel really heavy at the end of the day. Swelling that's sometimes either subjective, meaning they feel swollen and heavy, or you can actually visibly see pitting edema. You put your finger on the skin and it becomes a welt that doesn't come up for a couple seconds. Throbbing, restlessness, itching, or otherwise called pruritus in the medical term. I have many patients who say, I just sometimes in the middle of the night and I cause skin breaks because I just don't even know that I'm scratching the heck out of my legs because I'm so itchy. Cramps definitely can be caused by varicose veins. I want to make sure that I mention the fact that restlessness and cramps can also be caused by many other processes, disease processes, or illnesses. And varicose veins is definitely not the only cause, or they're not caused only by varicose veins, but varicose veins is one of the causes of these symptoms. As we progress from heaviness and achiness and swelling and throbbing, then eventually, to some patients, they developed cellulitis. Their skin become brown first in discoloration, then it becomes sometimes black and purple, very hard to touch, meaning it's no longer pliable. The skin is no longer soft to touch, it is actually quite hard to touch. Those conditions are called lipodermatosclerosis, or in other words, sclerosis or hardening of the tissue under the skin. And that's what makes it hard. And people develop what's called venous stasis dermatitis or venous stasis cellulitis. Those are advanced medical conditions caused by the same pathophysiology as what causes externally visible varicose veins, and they are on the route to becoming very medically dangerous. And then eventually that causes skin ulceration, which is a break in the skin of varying depth and size that can predispose that leg to lots of infection. It is painful. They seep. People who have ulcerations will say that they soak through their dressing because it is seeping fluid. The surrounding skin is dry and hard and not healthy, and I will show you some pictures of that. So we are already talking about lots of the medical dangers and conditions that varicose vein can contribute to. Okay, here are some examples of ulceration, venous stasis dermatitis, and lipodermatosclerosis. As you can see, here's a patient that has varicose veins in the medial thigh, and you can actually trace the process going down to this area of the calf and in the ankle that has an ulcer, and it has skin changes and discoloration. So that is what we call venous stasis dermatitis, venous stasis ulceration, or cellulitis. And if you were to touch that skin underneath, It is very hard and non-pliable. Here are some other examples of ulceration. In this particular patient, there is actually a dressing material, that's the blue color that is on the screen, but you can see the size of that ulcer in this patient. Here's another one. So I apologize for the lack of the appetite turning off of these pictures, but I definitely wanted to drive home a message that varicose veins is not just cosmetic. Here's a patient with bilateral lower extremity dermatitis and ulceration. Okay, let's talk about what causes varicose veins. So varicose veins, by definition, means that the veins that are normal, that are supposed to return blood to your heart, is no longer doing that. And why is it not doing that? It's because it's got broken valves. Every single one of our veins have valves in them, every single one of them, big or small. And that goes from the skin all the way to the big veins in your body. So these are just some of the names and some of the diagrams and schematics of the veins that we have. There are lots of other little veins and lots of other veins in our legs that are doing our drainage and return of blood to heart on a daily basis. When we speak of varicose veins and venous hypertension, or in other words, high blood pressure in the veins, most of the time we are talking about the superficial system. In this diagram, the superficial system is the lighter blue, the deep system is the darker blue. And this arrow points to one of the deep system called the femoral vein. What we are going to be mostly focusing on with patients with varicose veins are the superficial system. For example, in this diagram, this one called the great saphenous vein, and then in the back of your leg, this one called the small saphenous vein, or the lesser saphenous vein. These are the main veins to consider. There are many others that we all need to consider at the time of evaluation. And then you're going to hear me talk about perforating veins if you were to come see me. It's because these are the bridging veins between the deep and the superficial. They have valves too, and their valves are supposed to drain deep. But if those valves break, then they drain backwards, and they drain superficial, which makes the superficial veins even more abnormal. So it is actually very critical at the time of evaluation that we identify all the possible abnormal areas that the varicose veins can come from. Because if we don't catch them all and we treat one of them, two of them, but you leave a major factor in there, the veins will come right back. Okay, I will have some animation to show you what exactly does broken valves mean, and we're just going to go straight to that. Okay, so in this picture on the left are normal veins. As you can see, let's go back. Maybe we'll stop this right here. Okay, the normal valves are shaped like a teepee. So when you squeeze your leg and your muscles are walking, blood goes up, and then the normal valves open to let the blood go up. But when you relax, the valves close so that gravity doesn't pull those blood down. That is how we fight gravity in our veins to return blood from our feet back to our heart. In this picture, the valves are broken. So they're flipped upside down, and when you relax and your muscles aren't working to squeeze the calf, the blood just comes right back down with gravity. And over time, this vein that is supposed to be normal sized becomes bulging and big and dilated because of the pooling of blood in it, and that is what makes the externally visible varicose veins. So this process happens at every level of vein that we have. If it's the spider veins, it happens at the skin level. If it's the telangiectasias, it happens at even a slightly deeper level involving slightly bigger skin veins. If it's varicose veins, it happens at the veins underneath your skin that you normally don't even see until they become bulging and varicose because of this process. So again, I'm going to just play the schematic and you can see how the valves open versus not. Open and close versus not. Okay, I hope that made sense. Let's go to next slide. Well, okay. So what happens when we have varicose veins? I've heard so many patients come to me that say they've had it for years. They've gone to multiple doctors and they've been told to live with it. It's just cosmetic. Nothing can really be done. You don't really need to touch it. And then they say, but they hurt. I just feel like they're getting worse. I don't have any energy anymore. My legs feel really heavy and swollen, and I really want to understand what exactly is going on. So these are all the reasons that I hear that patients come to see me for evaluation and also treatment options. Exercise is great for us in many, many ways. And as you can imagine from that schematic, if you are less active, if you're more bedridden or less active, your muscles aren't squeezing as much, you're not helping your veins to fight that gravity as much, then you have an increased chance, relatively speaking, if everything else is equal, to develop varicose veins and venous hypertension. If you're active, number one, you maintain a healthier body weight and a healthier overall body habitus. Number two, your muscles are working and helping your veins to squeeze up and to return the blood. So healthier patients and more active patients in general have less, and they're more protecting their veins than those that are more stagnant. However, it is all relative and it is all a balance. There are many patients who are very active, who are triathletes, who are running, who are biking, who are on their feet all the time, and they come in with large ropey varicose veins because of many, many other factors that play into why a patient develops varicose veins. If you're on your feet all day, you are a operating room assistant, you're on your feet all day, you are a teacher, you're on your feet all day, that can wear and tear and have a toll on your legs as well. So yes, maintaining healthy weight and exercise are all great. It can help. It does not completely prevent, with many other factors that need to be taken into consideration. When you, and again, we've already talked about this, is, we talk about, oh, don't sit and cross your legs because you're pinching on your veins. You're causing more pressure for your blood to have to go back to your heart. Is that going to really prevent, if you're having symptoms and you're crossing your legs all the time and you're feeling like your symptoms are getting worse when you do that, then I'd say yes, that's probably playing a role. But is it going to prevent completely if you are going to develop varicose veins for other factors? Probably not. We'd like to put up our feet when we are watching a movie, when we are just sitting and resting for a prolonged period of time. That's just because we feel better about it and it's a more comfortable position. These are all things that I'm sure many of us have heard that will help. And yes, they do help, especially in patients who already have symptoms. They will not completely prevent. And as we get older, and if you're going to come see me, you're going to hear me say compression, 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 because it is really for all of us, with or without varicose veins, the best friend as we get older to our legs, because when we're not as active, when our tissues aren't as tight, that little extra extrinsic compression really helps our veins and our blood flow back to our heart. And when it comes to compression, if you can tolerate 20 to 30 millimeter mercury, and we're talking calf heights, they're not thigh heights, they're not pantyhose, just knee height compression, well measured, correctly measured, and well fitted, 20 to 30 can do a whole lot of good. And you will notice a difference. If you have achy legs, swollen legs, heavy legs, and you know you're going to be on your feet the whole next day, and you get a pair of good 20 to 30 compression socks, it'll make a world of difference to you for symptoms. Many patients can also tolerate a 30 to 40 millimeter mercury. They get pretty tight and pretty hard to put on. So I think in general, 20 to 30s for everyday application is plenty. There are some holistic or homeopathic methods that people have said that might help with development and also perhaps some symptoms of the varicose veins. And just like any other holistic and homeopathic treatment, they work for some people, they don't work for others. They're not harmful for you to try, but if they don't work, I wouldn't say, well, then it didn't work, and it's neither here nor there. It helps some, but not others. Okay, so wound care clinics have been around for many years. Boulder Community Health has a great wound care facility and a wound care clinic. If you have an ulcer and dermatitis and cellulitis, wound care clinic help you manage to dress those wounds and to care for them and to watch for signs of infection. Meanwhile, treatment for the underlying possible venous hypertension can happen at the same time. What are some of the treatment methods that are traditionally talked about? Vein stripping, meaning cuts along the leg and the veins are physically removed. And the stripping can be the varicose veins themselves or that great saphenous system that we talked about in the diagram, that's the superficial venous system. Phlebectomy is the same thing. It's basically a smaller version of stripping. So these are the previously accepted treatments that are more invasive. Today, we have, instead of stripping, we have heat and non-heat based ablation methods. So heat would be, you've probably heard of laser ablation or radio frequency ablation. And some of the companies, some of the terms are called EVLT, VNUS, or Venus. These are all some of the machines and names of machines that are out in the market that ablate the great saphenous and the lesser saphenous veins instead of stripping them. These are heat-based. And then we have the non-heat-based, which is what's called Varithena or Venocil, and those are more, for the lack of a better word, injecting a glue. It's not really glue, but it's injecting a sclerosant that then adheres down the walls of the veins instead of burning the walls of the veins to make them close. And we also, these days, do miniature versions of phlebectomy, which is called microphlebectomy, and sclerotherapy. We will talk about all of this individually. The number one key to success of varicose vein treatment, it's not the stripping, the laser, the technical aspect of the procedure. It's the ultrasound that happens at the time of consultation before you get on the surgery table or the procedure table. Because that ultrasound identifies the key areas of your leg that has the broken valves. You don't want to touch the veins that don't have broken valves because then they're good for you. You want to keep them in your legs so that they continue to work to return blood to your heart. But the veins that are broken with broken valves that are causing varicose veins and subsequent symptoms, those are the ones that we need to target to treat. It's like having an appendix, and if you have appendicitis, you're going to want to get rid of the appendix. You're not going to want to leave it in you. So having a broken vein is the same thing. We have many, many, many other veins that are healthy, that kick in right away and help us return the blood that should be returning to the heart. As soon as that varicose vein is taken care of, all that blood goes back to your heart in the normal way. I can't tell you how many times patients ask me, is it really okay to remove this vein or to burn this vein because am I missing a vein that's in my leg? No, you're only missing the bad one. There are many, many good ones that are actually important to keep and to maintain the healthy state by removing the bad one. Okay, so ultrasound is the key. And because of this, I do my own ultrasounds. It is important for me to lay an eye on the leg and the veins and the anatomy and to understand at the time of procedure what I'm supposed to do. I'm going to show you a picture or a video of what we actually find at the time of ultrasound. So here is an ultrasound showing, I don't know if you can see this well, a pair of valves in the middle of this vein. And when you squeeze the vein, in this particular instance, the orange is the correct direction. And as you let go of the squeeze, you can see the blue. The blue is the blood going in the wrong direction for this particular picture. So we actually do this ultrasound when you're standing up. I'm going to play that again. We do this ultrasound when you're standing up because we want to see live what your veins do and what your valves do when gravity is taking an effect. And then we count how many seconds is that blood in the blue color. There are specific insurance criteria and medical necessity criteria that these numbers have to meet in order to qualify for insurance coverage for treatment of varicose veins. And these are all well established time and time again and literature proven and study proven. So, and that is also what I use, that number right there, size of the veins and the amount of time that the blood is spending in the blue going backwards is partly what I take into consideration of how dangerous is this for you in your particular situation. So once the ultrasound is done, then I will have a very good idea of, are you a candidate for any treatment? Should you get treatment? What are some of the treatments that you should be considering? So once the ultrasound is done, then I have this conversation with you. It's all in one setting. It's done at the ultrasound department with a sonographer to type up numbers and to document information with me. And let's just say you say, yep, this all makes sense, and I want to go through with it. Then we submit the whole information for insurance authorization. And once insurance approves, we call you to schedule the procedure. So that's the process at Boulder Community Health. Then on the day of your procedure, you would have a pair of compression socks that I would have prescribed and giving you instructions on where to get it, how to get it, etc. And you get on the procedure table. It's in the interventional radiology suite. Everything is sterile. Myself and my assistant and my technologist would all be in sterile gowns and masks and gloves. And we do the procedure in a very sterile environment. Infection is definitely a risk with any procedure, but this is how you prevent it, and or at least as best as you can. And the leg is prepped. Any extremity body part that needs to be treated is surgically prepped. Some people who, I put on here conscious sedation if needed. We do the laser ablation and the sclerotherapy all pretty much with local anesthetic. The microphlebectomy, and I'll show you pictures of that, We do give conscious sedation for that because it is a little bit more involved than just laser and sclerotherapy. But I definitely have patients who say, you know what, I'm really anxious and I really don't want to get needle poked and know it. Then we can do sedation for any of it or all of it. Okay, so here is an example of what the laser procedure looks like. This diagram shows a varicose vein. Again, there are other non-varicose veins in the leg that are the normal veins. And in this diagram, you already see a laser catheter that's already been inserted into that abnormal vein. So prior to this picture, the leg's already been prepped, I've already numbed up the skin, and I've already inserted the laser catheter. And then what happens is we numb up the skin around this vein with what's called a tumescent anesthesia, and that helps protect the skin and the surrounding tissue from being burned once the laser is turned on. Because the laser is only supposed to treat the vein itself. So here's what happens. We have this needle is showing you administration of tumescent anesthesia, which surrounds the vein. And then you have a little skin nick that inserts a catheter, which then helps insert the laser. And then everything is guided to where it needs to go. Then laser is turned on and pulled back. And as the laser is pulled back, the vein is ablated. Okay. As this happens, over time, that vein gets absorbed, and 6 months later, if you were to do a repeat ultrasound, it's as if it was never even there. Your body completely resorbs it. So the amount of blood pool that was going into that vein, that was causing your heaviness and your achiness and your skin changes, all that is now rerouted to all the other veins that are in the leg and going back to your heart. So this is very helpful to establish healthier circulation than otherwise. This is an example of ultrasound-guided sclerotherapy. I do all of my sclerotherapy for the deeper system with ultrasound guidance because you need to make sure that the sclerosant gets exactly where it needs to go, which is inside a vein. So what is sclerotherapy? Sclerotherapy is a liquid injectant that we use to treat veins that are too serpiginous, too small, too tortuous for laser treatment. So laser treats the straight, big segments of bad veins. Sclerotherapy treats the not so straight, littler side branches that are also broken that need to be treated, because if you don't treat those, they're just going to feed back and create more varicose veins on their own. So here's an example of sticking it by ultrasound guidance, put a needle into a vein, and then injecting that sclerosant, which is that bright white line that's showing up on this video. I'll play that again. It's very hard for me to record my own procedure because I tried multiple times and it doesn't, well, we can't actually record a cine of an ultrasound to put on my phone, so that was a little bit of a challenge. But this is exactly what happens. Okay, so that's sclerotherapy. So now, let's talk about microphlebectomy. You have these ropey varicose veins. You've gotten rid of the main bad underlying great saphenous vein by laser. You've injected the sclerotherapy into the other tributaries that are also contributing to this. But we know from experience, given a certain size of already present varicose veins, they're just going to want to stay open because the cavity is already there. So yes, you can get rid of the feeders as much as you can, but if you keep the cavity there, these cavities are just going to want to feed back from other mechanisms and therefore increase your chance of developing alternate bad broken valves otherwise. And in order to get rid of them all completely, you have to do some degree of microphlebectomy. So what is microphlebectomy? It's on a day of your treatment, I get you on the upright position, and we map out the actually externally visible ropey varicose veins. Okay, so we map them out. These are pretty extensive examples of what microphlebectomy can be. And then because once you're in the supine position, these veins flatten out, and I can't see them anymore. So we map them and draw them out when you're in the upright position. Then you get on the table. Again, this is a patient with mapped out vein. The leg is again prepped. That whole area of mapped out vein is anesthetized, and we actually remove these veins. And you do little tiny stabs, as many as it takes to remove the veins. So that's called microphlebectomy. It is a miniature version of the previous surgical stripping. The goal of all of this, okay, resolve the varicose veins, and we're not talking just cosmetically, we're talking getting rid of the medical risks. Preventative, and then with patients who have the dermatitis and the ulceration, it's to heal their ulcers. Okay, so we'll have some pre and post pictures. So varicose veins pre and post, as you can see in this patient. This is about 2 weeks out in general. All these pictures are about 2 to 4 weeks out, so they would still have a little bit of bruising, but you can see the veins are mostly taken care of. That's the patient that we did the laser and a sclero and the microphlebectomy, as you can see by the drawing. And that gets rid of the ropes. The ones in front of the knees are super hard to treat, and that's pretty much everyone. But you can see in this patient, there's big ones in front of the knee, and then there's big ones in the ankle, in the front of the ankle, and those look much better afterwards. And this is basically 2 to 4 weeks. Smaller varicose veins all over this lower extremity, back of the thigh, side, and inner. And you can see the little tiny stabs at 2 weeks that are still healing because of the microphlebectomy. Okay, so this is that patient, 2 weeks out with the microphlebectomy. The incisions you can't see, they're very, very small. There is some bruising, but the veins are gone. And here's that patient with the ropey varicose veins. And again, 2 weeks out, the veins are mostly gone. And these will continue to resorb and go away. I remember this patient very well in that this was a competitive skier. And this person could not ski because of the amount of ropey varicose veins that were pressurized because they couldn't stay in their boots. Because of this amount of ropey varicose veins. And afterwards, it was a much better experience. Here is ulcer patient. Treat the varicose veins. The ulcer starts to heal. This whole area of discoloration is much better. Ulcer is now a little guy, continuing to heal, ongoing process, but it is much healthier for this leg. And this is that patient. So this patient has the ulcer and a birthmark, which is that red underneath the skin. It's actually his birthmark, but you can see the ulceration. I treated this patient in September, and it literally was closing in front of your eyes. This is December with his birthmark and the ulcer much, much better. This is a patient who has lived with this for 15 years, whose doctors constantly said to him, "There's nothing I can do for you. There's nothing I can do for you. There's nothing I can do for you. We'll just keep treating the sores. We'll just keep treating the ulcers. We'll just keep dressing the ulcers. We'll keep putting you on antibiotics." And somebody along the way said, "I wonder if there is venous hypertension under this. Let me send this patient for an evaluation." And sure enough, there was very badly broken gray saphenous system with all the valves broken, and you treat that, he didn't have to live with this for 15 years. Okay, so telangiectasias and spiders. Now we're going to focus the talk on some of the more cosmetic things. Many patients who present with varicose veins will also have telangiectasias and spider veins. And you're gonna want the ropes gone, and you're gonna want these clusters gone. So what are we gonna do for these clusters? Let's see, pre and post pictures. So here's me, here's the pre with this leg and this area completely prepped, and I'm injecting these veins with sclerotherapy. So the point of this post picture is I want everyone to know, once you inject it, it flashes like that other video, it goes away. Within about 5 minutes less, they all come back looking angry and mad. So before you have brown, purple, blue veins. After I treat, you're gonna have red, pink, angry looking veins. This process will last about I'd say 3 to 5 weeks, gradually getting better. When this redness goes away, the veins are gone for good. Now, so basically when we do this, don't expect to have gorgeous looking legs right away. The other point of this is that, let me show you this other, this is also injection, and then you get, the veins are normally these small looking veins, and then you get the redness that occurs right after. So you put compression socks on, and I see you back in a couple weeks, and most of them are much better looking, and then 5 weeks later, they're mostly resolved. However, you can imagine many patients come with many of these spider veins. They're all over the leg. That one syringe of medicine is not going to be good enough to cover all of it. And there's only a certain amount of sclerosins that we can put in a leg safely at one time. So that is why you will hear myself and many other people who do this, that you got to come back multiple times for repeat treatments to get it all. Okay, that pretty much covers the gist and the big picture of what is happening with varicose veins. There are many other processes deep in our body. This is only an example of it. It's called gonadal vein insufficiency that I also pay attention to at the time of evaluation to figure out, do you have this or do you not have this? If we find this, this also needs to be treated, but it's a completely different treatment. Many people don't even actually think about this. And there's also another physiology involving the iliac veins that's called May-Turner syndrome, et cetera, et cetera. There are many, many causes of varicose veins, some of which we can externally see below the legs. Others are inside the belly that we can't see. The key is to identify them and to treat them, so to completely prevent them from recurring. And that is all I have for today.
Thank you, Dr. Mao. That was very informational. Appreciate that. We want to remind our audience that now we're at the time for our Q&A, and so you can submit your questions below the presentation, and we will get to as many as we can tonight. We're just going to dive right in now. So if you have had a venous ablation, can you have the procedure again?
So the answer to that is depends on what's left. If you've had a venous ablation and what was taken care of before is truly gone, and you now have recurrent varicose veins, it's the ultrasound and the consultation to figure out what's causing the recurrent varicose veins. Sometimes it's brand new vessels that have become abnormal and it has nothing to do with what was treated before. Then you got to treat that one. Sometimes it's what was treated before actually didn't stay closed. It reopened back up. So then the answer is absolutely, then you got to retreat the same place. But you won't know that until you do the evaluation.
Okay, good to know. Can you put too much compression on your legs?
So by too much, so the answer is yes, and the only reason why it's yes is because compression that's correctly measured and correctly fitted should never be uncomfortable. As a matter of fact, it should be extremely uncomfortable. I can't tell you how many patients I have convinced, just try it. And they come back to me and say, you are so right. They are absolutely the best thing. I wear my compression socks every day because I'm on my feet all day. There's hot summer days I don't like to. And then at the end of the day, I want to just, they're just crawling into your skin and I just want to peel them off. But otherwise, my legs feel great with them on relative to not. So poorly fit compression are either, and by that I mostly mean too tight ones. They're too small. They probably weren't measured correctly so that they don't fit you and they fit you too tightly. That can be dangerous. And that is what I mean by can you be over compressed? Because then that cuts out arterial circulation. That gives you numb feet. That doesn't really gradually, fix the edema. It more than chokes the edema at different ends, and then you've got swollen toes versus swollen knee. So gradual compression and correctly fit compression should never be uncomfortable. And then as far as what grade, whether it's 20 to 30 or 30 to 40 or 40 to 50, again, that depends on what you can tolerate. And if you have legs that are so heavy and abnormal that you need the 30 to 40 and the 40 to 50s, for example, some of these ulcer patients, they have they have custom-made compression grades for them. 50 to 60 will be over-compressing me, but not them. So it's relative.
Can you wear them all the time, day and night?
I would not recommend them during the nighttime just because, well, if it really feels that comfortable, and let's just say you have cold feet and you have cold extremities and you need stocks anyways, and you don't feel bad with them on, there's no medical contraindication to wearing them day and night. But I don't know many patients who actually want to do that. I mean, usually it's daytime and then you will want to take them off at night just to give your skin some breathing.
Okay. Any stylish ones?
There are many websites, honestly. There's actually quite a bit of websites that come with all kinds of wonderful patterns.
Good to know. So will the compression stockings decrease spider vein and the coloring with that?
Decrease
spider veins and the coloring with spider veins?
So compression, when applied, correctly, they help with symptoms and they help slow down progression. They don't resolve them. So if you have spider veins and you want to slow down the making of more, wearing compressions in general helps with better circulation. Or support stockings help with better circulation. But once you take them off, they're going to come right back. So they don't resolve them. Compression doesn't resolve them.
Okay. So this person had spider veins removed by the needle injection. They came right back in just a few months. Is today's procedure more long-lasting? This was about 12 years ago.
It depends on what was injected. I think 12 years ago was probably saline. They used to use saline, which is it's hypertonic saline. It's extremely painful for injection. Did it actually go in the blood vessel or did it go around it? It's very hard to say why it came back within such a short period of time. Because there's many factors that contribute to it. Could they come back with even given the best case, best technique, best injection? Yes, because when we have the propensity to grow veins, we might just grow more veins. So I'm not sure that it means better or worse, right or wrong.
Okay. So are these procedures outpatient?
They're all outpatient.
Okay. So this person is 84. Is that too old for treatment?
That's relative. If you have ulcers and you're 84, I don't think you can, my oldest patient just saw me. I've seen her for 12 years now. She's now 95. She had very bad ulcers. So is that too old to get healthy legs? No. I mean, you don't want ulcers at any age.
Okay.
But if you're 84 and you tell me, I want you to go to town on my spider veins because I want to have beautiful legs.
Okay. Can you get blood clots from having varicose veins?
Yes. So one of the biggest medical risks, other than local, regional in the legs, is having a blood clot. Pooling of blood or stagnant blood creates blood clots. Blood clots can travel. So a blood clot in a varicose vein can travel to the great saphenous system, which in turn is connected to the deep system. So it can travel to the deep system, which in turn is connected to your heart and lungs. So it'll eventually end in your lungs. And we've seen that many, many times.
Talk about insurance. Does Medicare cover it?
Yes.
You mentioned some criteria for
Yes.
some insurance. Can you talk a little bit to those points, please?
Every insurance is different. So Medicare covers as long as you qualify Medicare criteria. And every insurance have a different name for the vein. They have a different numbering system for the vein. So we know that there is a minimum size of a vein. We know there's a minimum reflux second number. That number where the vein stays in blue, that needs to be met criteria. Your clinical presentation, your symptoms need to meet criteria. There's a whole categorization, it's called CAP categorization of, or CAP classification of varicose veins. So all that goes into the report after the ultrasound evaluation. And that is what determines, that is what helps the insurance company determine, are you medically indicated or not? Now, so with that being said, I have had insurance companies turn down patients with ulcers, okay? Not usual, not common. So we fight them. If there really is a medical indication, and I feel truly strongly that, you know, they're just making a bad decision, we appeal. I call the medical director and we do peer-to-peer reviews and we fight them, and we're pretty successful at it.
That is good to know, especially when it's necessary like
Well,
that.
insurance companies don't necessarily make, you know, best decisions sometimes.
So as far as prevention or dealing with it, you said, you mentioned several things. You mentioned exercise, you mentioned supplements. Is there anything topical to put on your leg? Okay, so some people will say vitamin E, creams with good quality vitamin E. I want everyone to be careful because you don't want to overdose on vitamin E. Although most of these creams, they're considered medications, so they need to be FDA approved, and which means they have certain dosage of vitamin E that they're allowed to have in their cream. So they're in general safe. There's not a single cream out there that I know of that actually prevents varicose veins. I think the most important thing is to keep a healthy skin. So if you're developing varicose veins and you're getting that swelling and you're getting that skin color change, keeping that skin as healthy as possible rather than dry and flaky is going to be more helpful than not. So can the varicose veins heal with these measures?
They don't go away. Once you get them, they don't go away.
Okay.
They will only progress. You can do things to slow down the progression, such as exercise, elevation, compression, etc., but they won't resolve them.
Okay. Back to insurance. So if you're getting a varicose vein treatment and you want to get some spider veins treated at the same time, how does insurance deal with that?
It's sclerotherapy. Spider veins are sclerotherapy. When I do varicose veins, I do sclerotherapy. They don't know what kind of sclerotherapy, so I just do it all at once. Now, if you only have spider veins and I have nothing else that I can say that's a laser candidate or an ultrasound-guided sclerotherapy candidate, then that's self-pay. Because that is truly just cosmetic.
So you had mentioned some of this instance of varicose veins in other parts of the body. Do you assume that you're going to have other parts of your body with issues if you have this in your legs?
No, we look for that at the time of the ultrasound. I have a very good sixth sense about, is there something else going on that we're not seeing?
Besides heredity, are there things like diabetes or even knee surgery where they're messing with?
Absolutely. Trauma. Number one is trauma or history of trauma. Back when I was 10, I fell off my bike and I really hit my shin hard. 15 years later, you've got a wad of giant ropey varicose veins. Because that trauma traumatized the valves of the veins under the skin. You didn't know it at the time, and then it took 10, 15 years for the whole kit and caboodle to develop. So trauma, absolutely. I don't think diabetes. Diabetes affects more arteries, not necessarily veins. What else? I think trauma and central obesity.
Okay. So everybody's different. Some of us are small, some of us are large or tall. Do smaller people have smaller veins, and does that matter with any of this?
Nope.
Okay. Let's see if I can pronounce this one. How do you know if the swelling is from varicose veins or lymphedema swelling?
Right, you don't until you get the ultrasound. If your ultrasound
so the ultrasound will tell you
got to
that.
get the evaluation. You don't otherwise. If your ultrasound shows normal veins, then then there's something else.
Okay. This person has varicose veins, both legs, but only one of their legs swells up. Is that common, and can it be treated?
Yes, it's very common. It's very common. It's very common to have veins on both legs and one leg worse than the other.
But you still would address both of the...
You look at both at the same time, yes. You do an ultrasound to look at both.
Okay. Do you recommend a specific brand of compression hose?
Do I recommend a random compression hose?
A brand?
Oh, a brand. I personally like Sigvaris. It's a medical compression company. Sigvaris as in Sigvaris, I want to say. RIS or RUS? I think it's RIS. I think they're very comfortable. They're very well fitted. They are very good quality. They don't break. They're not cheap.